Hello and welcome to today's program, Health Equity and Well-Being from the Start, Building Support for an Equal Opportunity Childhood. My name is Leslie Erdoak with the Association of State and Territorial Health Officials, and we're happy that you've joined us and look forward to spending the next 90 minutes today talking about principles of health equity and why it's such a critical factor in early childhood development. This is the fourth in a series of webinars that ASTHO has hosted in partnership with the CDC Injury Center, featuring the Essentials for Childhood framework, which has served as a platform and as a roadmap for highlighting strategies that promote safe, stable, and nurturing relationships and environments for children and families, because we know that these things are key to protecting against maltreatment and other adverse childhood experiences. Healthy relationships in childhood have been shown to stimulate brain development, and they really are the building blocks for a healthy future. For those who are joining us for the first time, welcome. And for those who have been a part of this ongoing dialogue and who have participated in the past, we welcome you back. Part of why we're here today is because research has documented the importance of social and economic conditions and opportunities as they relate to health. And it tells us that the disparities that we face or the discrimination that we might experience during childhood very often plays a role in shaping our future health outcomes. Inequities can also indirectly affect early childhood development if the social disadvantages and discrimination experienced by the parent or the caregiver, for example, affect how they're able to care for the child. Understanding how disparities are created and how they influence health and health care starting early and through the life course is paramount to developing strategies and other programs or policies that put health equity at the forefront. We have three individuals here with us this afternoon who have such a depth of knowledge on these issues, and we'll hear from each of our presenters momentarily. We'll set the stage with a discussion on a framework for advancing health equity, and our presenters will also share with you later in this hour some of the approaches that they are taking to address health equity and early childhood development in their states. Our objectives for today's program are displayed on your screen, and you'll see that what we hope to address are the why and the how, and that we hope to give you some ideas for how you might be able to work with others. Whether it's through your health department or through your local community partners, we want to showcase a number of strategies that you might prioritize or that you might consider in your work to create safe, stable, nurturing relationships and environments for all children and their families. Before we get started, I want to remind everyone that you can submit a question at any time through the chat box feature located in the lower left-hand corner of your screen. After each presenter has finished, we'll take one or two questions from the chat. And then at the end of our program, and after all presenters have gone, we'll return to the list of questions and invite any and all of our presenters to weigh in during a question and answer session that I'll moderate. At the end of the webinar, you'll be directed to a web page and asked to complete a brief evaluation of today's program. We appreciate your thoughts and suggestions, and so we encourage you to respond and share them with us. Please also know that a recording of the webinar and all presentations will be shared with everyone who registered for today's program. Now I'm pleased to introduce our first speaker of the afternoon. Marilyn Metzler is the Senior Analyst for Health Equity in the Division of Violence Prevention at the Centers for Disease Control and Prevention, where she leads efforts to integrate a health equity approach across research, surveillance, and program activities. She's co-authored multiple publications, and she's a member of the CDC Health Equity and the Healthy People 2020 Social Determinants of Health work groups. Marilyn is a registered nurse with a degree in philosophy from Smith College and a master's in public health from the Morehouse School of Medicine in Atlanta. Prior to arriving at CDC in 1999, Marilyn was the regional coordinator for community health education at the Dartmouth-Hitchcock Medical System in New Hampshire. And with that, Marilyn, everything looks good on our end, and I'll invite you to please begin.
Thank you, Leslie, and there we go. All right. Welcome, everyone. It's just a thrill to be able to spend this time with you talking about health equity. Thank you, ASTHO, for all your support. You've just been wonderful. And I also want to give a special thanks to my colleagues here in the Division of Violence Prevention, and particularly the Essentials for Childhood team. You guys are just a pleasure to work with every day, so thank you. I want to remind you all that the findings and conclusions in this presentation are those of the author and do not necessarily represent the official position of the Centers for Disease Control and Prevention. The Division of Violence Prevention's mission is to prevent injuries and deaths caused by violence and to stop violence before it occurs. And we know that preventing violence requires understanding the behaviors and the context in which violence occurs. In my talk today, it's really a general introduction to health equity with a focus on early childhood and the prevention of child maltreatment. I'll begin speaking about some concepts and related science from related to health equity, introduce a framework for health equity research and practice, and then we'll use that framework to explore inequities and risk for child maltreatment. I want to begin reminding us that as the Institute of Medicine stated in 1988 and again in 1997, that public health is what we as a society do collectively to assure the conditions in which all people can be healthy. And the all is added there for emphasis and very relevant to our work in health equity. And assurance is one of our core functions in public health. So our work from health equity really springs directly from our mission in public health. I want to begin by having us just think for a second about what drew us to public health. Maybe we were interested in helping people keep healthy. We were maybe interested in everyone wanting to have a good quality of life, create safe communities. And these images probably reflect what many of us brought to our public health work. We're really very invested in happy, healthy, and thriving individuals, communities, and societies and environments. But we're also in public health, we're interested in the big picture, and that's part of what makes working in public health so enjoyable. And so being able to look at that big picture is very much a part of health equity work. So we'll go ahead and begin with a few definitions and concepts. Health equity is a vision statement. It's an understanding of what the world could look like. There are many definitions of health equity, and many of them are framed in terms of the absence of something bad. But this one here is positively framed, and it's very aspirational, and it does come from the Health and Human Services Office of Minority Health from the National Partnership for Action to End Health Disparities. So health disparities is really the differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist between population groups. For example, women have a higher rate of breast cancer than men. Both can get breast cancer, but women have a much higher rate for biological reasons, and that is a type of health disparity. But when women of color are more likely to be diagnosed later and die sooner than white women because of breast cancer, that's something different. That's an inevitable difference, and it's considered avoidable. And it's considered a health inequity, which is defined as differences in health status between more socially advantaged and less socially advantaged groups caused by systematic differences in social conditions and processes that effectively determine health. And health equities are considered avoidable, unjust, and therefore actionable. And this is an adapted definition from Paula Braveman. In order to understand what might be driving some of these health inequities, we take a look at social determinants. And here we use a definition from Sherman James that social determinants are life-enhancing resources such as food supply, housing, economic and social relationships, transportation, education, healthcare that effectively determine length and quality of life. And they include the processes by which these resources are distributed across populations. There's a huge literature that has emerged, particularly over the last decade, in showing these inequities across virtually all diseases, injury, violence, and other health outcomes. They show patterns in both absolute and gradient relationships. They have been shown to occur over the life course and across generations and geographically within and across countries. So how do the social determinants impact health? A very high-level summary of the pathways and mechanisms include access to material resources. For example, it's hard to be healthy if you do not have access to healthy food, a safe neighborhood. Also stress, including the lack of access to material resources, the stress caused by that. Social exclusion, not feeling a valued member of your group or society. Discrimination can contribute to stress, and toxic stress, chronic, enduring stress that lasts over a long period of time. And then also epigenetics, where stress can influence how genes are affected by their environment. There's growing interest in social determinants of health and health equity. The World Health Organization convened a commission on social determinants of health from 2005 to 2008. Healthy People 2010 and 2020 have had an emphasis on social determinants of health. The National Prevention Strategy and National Partnership for Action. Many state and local health departments, we'll hear from 2 today, and then membership organizations including ASTHO, NACCHO, Safe States, and many others, and lots of community organizations are now understanding the importance of addressing these health inequities. So now we're going to take a look at frameworks, and this is serious and complex work, so we need a framework that can help us to make sense of a lot of these concepts and the data and the evidence that we do have. And this disclaimer here that all models are wrong, but some are useful. It's generally attributed to statistician George Box from Britain. It's just a reminder that none are perfect, but they can help us. And in this next slide, we see a series of frameworks, particularly the one in the upper left-hand corner, the socio-ecological model from the Institute of Medicine, that really has provided so much help for us in understanding in public health and how the social and community environments can impact individual and family health. But these other frameworks from Healthy People and also from the National Prevention Strategy, they're all depictions, sort of mental maps to help us try to show these relationships. But none of them really have the specificity to help us understand how health inequities are generated and how they persist. So we need a framework with some more specificity. And the WHO developed one during its work, and I just have a little comic relief here with this slide because the framework is necessarily complex, but we're going to unpack it and take a look at it and make it hopefully more accessible. So here's the framework, and as I mentioned, there's a lot going on here. There's lots of arrows. The beauty of this framework is it's very grounded in the literature. It's grounded in epidemiologic evidence and social and political theories, and it's just one of the most robust frameworks I think that we have in order to understand health inequities. So now we're going to just take a very high-level walk through it to make it a little more clear what's going on here. So in public health, we often start with the data, and on the far right-hand corner of the framework, there's an outcomes box. And in a health equity analysis, you look at population health, but also we want to be able to disaggregate health. So then the framework walks back into the intermediary determinants of health. And in this box, we have material circumstances, such as living and working conditions, the availability of food, and also behaviors and biological factors, psychosocial determinants, and then the health system. And these are often, particularly the material circumstances, are referred to as the social determinants of health. And then the framework walks back into looking at socioeconomic position, which is generally understood as aligning along social class, gender, race, ethnicity, and can be determined by your access to education, occupation, and income. And your socioeconomic position can determine if you have more or less access to these living conditions, the intermediary determinants of health. And then taking a step back, the framework looks at the structural determinants that effectively help to create your access to socioeconomic position by groups. So through governance, through macroeconomic policies, social policies including the labor market, housing, and public policies, education, and cultural and societal values. And the framework also has a very important cross-cutting box defined here as social cohesion and social capital. And it's really the theory of change for what it would take to change these conditions so that we would get a different set of outcomes to address health inequities. And in its white paper on this framework, the Commission was clear that this is where we have the most to learn, how we can really build the capacity to change the structural and intermediary determinants of health. As I mentioned, it's not a perfect framework. There are some limitations. It does contain mixed constructs. It omits some groups. It does not account for life course influence. It doesn't account for historical influences. And it implicitly incorporates, for example, racism and gender inequality, but they're not explicitly noted on the framework. But it also has a lot of advantages to help us explain how inequities are created and perpetuated. And it incorporates specifically an intersectional approach so that we can have a deeper understanding, for example, of social hierarchies and how they can vary by both race and socioeconomic position, for example. In the cross-cutting box, it considers human agency. And very importantly, people are using this framework to really foster a growing global conversation and to develop effective actions to address health inequities. So it's been very important as a resource and a tool. And in fact, we can use the framework to develop hypotheses and explanatory pathways. You can also use it to identify where you are working and based on that to set reasonable expectations for outcomes that you might expect. And you can use it to build on existing approaches based on new evidence and a new narrative. So we're going to use the framework, as I mentioned now, to look at the concepts related to inequities and risk for child maltreatment. And so we're going to use it to sort of develop hypotheses and explanatory pathways. And looking at the question, preventing child maltreatment requires understanding why some children and families are at greater risk than others. And this work was developed for a chapter that a group of us here in the Division of Violence Prevention developed that is forthcoming in a book on public health approaches to preventing child maltreatment. So we know that in the U.S., the overall rate of child maltreatment is 17.2 children per 1,000. We know that there is a distribution by race ethnicity such that African American children have about twice the risk of white children. And by income, children living in low SES households have about 5 times the risk of children not living in low SES households. And we can look at these numbers and ask, is this something about bad parents, or is this something about the conditions in which parents are trying to raise children? Now, we are all working for a world where no child is ever maltreated, but to get there, we really have to understand why some children are at greater risk than others. And working to close these gaps is essential to advancing our work on health equity. So we're going to take those data and map them on the framework. And then we're going to walk back and ask, well, what are some of the intermediary determinants that might be associated with this differential burden of child maltreatment? And here we looked in the literature and saw that child maltreatment often correlates with poverty and low family income, parental unemployment, residential instability, living in a high poverty neighborhood, and living in a high violence neighborhood. And then we asked, well then, what puts people at risk of being in these conditions? And to do that, if you remember from the framework, we want to look at patterns of socioeconomic position that may contribute to groups having more or less access to the intermediary determinants. And here we look at census data and Bureau of Labor Statistics data and just saw patterns that repeated, such that education, lower rates of high school completion, for example, by race, ethnicity, and also by socioeconomic position. Children in poverty are twice as likely to not complete high school. In terms of occupation, what might contribute to being at risk for unemployment? Adults without a high school diploma are 3 times as likely to be unemployed as college graduates, and African Americans and Latinos are twice as likely to be unemployed as Asians and whites. And in terms of wealth and income, we learned that blacks and Latinos are 2 to 3 times more likely to be poor than whites and Asians, and that at all levels of educational attainment, blacks and Latinos earn less than whites. African Americans and Latinos with master's degrees have lifetime earnings lower than whites with bachelor's degrees. And 36% of poor children live in households with incomes less than half of the federal poverty line, compared to white children, for example, 30%, or Latino children. So children of color are not only more likely to be poor, they're more likely to live in deep poverty. And we also learned that median wealth of white households is 20 times that of black households and 18 times that of Hispanic households. So that is represented here on the framework. Then we looked at just a series of policies and reports, not looking to establish correlation or causation. This is just a conceptual framework, but what might be contributing to these outcomes along these socioeconomic patterns. And in terms of education funding, high poverty neighborhoods receive less dollars per student than low poverty neighborhoods, and that can translate into the high poverty schools having less stable and less qualified teaching class, which of course can affect your educational attainment. The cost of college we know is going up for all families in America, but it's disproportionately affordable for families with the lowest incomes. In terms of mortgage lending, we learned in one study that in a review of mortgage lending data, home mortgage lending data, that looking at 100 largest cities, in more than 70% of those cities, African Americans and Latinos were more likely to receive a high interest, high cost loan than white consumers within their same income groups. An example of differential impact of hiring practices, there are studies, multiple studies now, that show that employers in the U.S. are more likely to hire a white person with a felony conviction than an African American person without a felony conviction, even when both applicants have otherwise comparable credentials. And in another study, this published by the National Institutes of Health in a review of their grant funding programs, a study showed that black PhD scientists were less likely to receive NIH funding for a research idea than a white scientist with a similar institution with the same research record. And in their writing up of this in Science Journal, they said themselves they're not really sure how that works, but that they were committed to looking at how that was operating in their organization. And within the justice system, we know that African American whites have comparable rates of illicit drug use, and yet African Americans are far more likely to be sentenced to prison than are whites, and they're more likely to spend a longer time in prison than whites for the same offenses. So when we put these on the map, we start to have, as I said, sort of pathways and mechanisms that might explain some of the stressors that are on families, some of the societal processes that make it more challenging for families to raise their children, and that many of these are outside the ability of families to change these things themselves. We then used this information and did sort of a rapid assessment here in the division. This was a couple of years ago with all of our team working on child maltreatment prevention research. You see the key at the bottom, pink being surveillance, blue research, and green were our practice activities. And we saw, not surprisingly, that a lot of our efforts were more on the right side of the framework, and all very important work in child maltreatment prevention. Evidence-based parenting programs, we absolutely need those. Intergenerational transmission of child maltreatment, understanding how that works. Training for therapists, development of ICD-9 and 10 codes for abusive head trauma. Very important work. We had one study looking over at socioeconomic position, looking at the impact of child maltreatment on high school non-completion. Since we did this, we have added a little more work in these areas. On the left side, you see Clevens and colleagues have recently completed a scan of policies shown to be effective for reducing physical abuse and child physical abuse and neglect. And Melissa Merrick and colleagues have also convened a panel to look at new analyses and measures of safe, stable, nurturing environments and conditions. So it's all very exciting work. And in the cross-cutting box, building our capacity to address and work across the framework, we have the Essentials for Childhood initiative that many of you are familiar with. But we're also learning now about changing the narrative. And I mentioned a minute ago, this larger picture of looking at this helps us to expand that narrative from sort of fixing bad parents to understanding and addressing the conditions in which many families are raising children. Part of that work includes The Raising of America, Early Childhood and the Future of Our Nation, a film to be released this spring that we are partnering on, and that we'll actually have a webinar, an ASTHO webinar on in March, and new partners and new strategies. So this is an example in this next slide of using indicators across the framework, and they're really small and we're not going to go through them, but it was an exercise that we did as part of the Essentials evaluation work on, you know, what could we do to actually monitor to see if there are changes in these conditions, you know, over the course of our work. It's just an example. And all of this, of course, is consistent with our Essentials for Childhood work, which is assuring safe, stable, nurturing relationships and environments for all children. So what we're learning is that it's important to have a conceptual framework as a guide. It's important to be explicit about what it means to bring an equity lens and to use the best available evidence to learn while doing. We're also learning that people are really energized by this cohesive approach, that we can actually make sense of this. And we also know that it's the right thing to do for all children and their families. And in summary, you know, a health equity approach allows us to understand differential burden, differential risk, differential exposure, and then the differential impact of interventions as we work to assure the conditions in which all people can be healthy. And I just want to leave you with this last slide. We saw initially that health equity was defined as attainment of the highest level of health for all people, but the rest of the definition goes on to say, achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Thank you very much.
Thank you, Marilyn, for your remarks and for providing us with an excellent foundation for our conversation today. I'd like to take this opportunity just to ask you briefly for your thoughts on a question that was submitted during your presentation, and it has to do with the data that we have available and that we cite on child maltreatment. The question is, how is child maltreatment defined? Is it just substantiated reports that goes into those numbers that we consider our data? And we acknowledge that there's often bias in those numbers. So could you comment, Marilyn, on how CDC defines child maltreatment?
I could best turn to my colleague Joanne sitting next to me, who can give you CDC's definition of child maltreatment. Joanne, could you answer this question?
We have a very comprehensive document that defines what we mean by child maltreatment, and I don't have the definition.
Marilyn, thank you. I'm going to step in just for a moment. The audio is not coming in as clear as I think many of us would like. So what we're going to do, we'll return to that question at the end of our program, and we'll invite your colleague to speak up later on today, because I think it's a really important question that we address.
Thank you.
Absolutely. And so just to keep us moving, I'd like to move on to our second presentation, and we look forward to other questions as we move through the program. So please remember to submit them for us, and we're keeping track of those that are entered, and we'll address them at the end. So I'm delighted to introduce our next presenter, Dr. Ed Ellinger, who was appointed to serve as the Minnesota Commissioner of Health in January 2011. Prior to his role as Commissioner, Dr. Ellinger served as the Director and Chief Health Officer for Boynton Health Service at the University of Minnesota from 1995 to 2011. He's also served as an adjunct professor in the Division of Epidemiology and Community Health at the U of M School of Public Health. He's earned numerous honors from the Minnesota Public Health Association, the Minnesota Medical Association, and City Match. He is also President-elect of ASTHO. So again, I'm pleased to introduce you, Dr. Ellinger, and you may now begin.
Great. Thank you, Leslie. And thanks to Marilyn and your team for all of the work that you've been doing on the essentials of childhood and that framework, which you'll see as I present that we've been using that, and certainly we've been using that as we worked on the social determinants of health and our COIN work on infant mortality. It's been very, very helpful to have that framework and all of the work that you've done on that, so thank you very much. And it's nice to be talking to this large group of folks as I scroll through the list of people on there. There are many people that I know, so hello to all of you, and I hope I get to meet all of the rest of the 800 that are on there that I have not met before. So I'm going to talk a little bit about what we're doing here in Minnesota to focus on early childhood and the social determinants of health and health equity. And certainly, we have to start with the fact that we have to acknowledge that it's Victor Hugo's birthday today. He's the one who wrote The Hunchback of Notre Dame and Les Mis. And I put him up here because he was a social reformer, and particularly he worked on a lot of social justice issues, but really worked a lot on the death penalty issue. And he said, there's nothing like a dream to create the future. And I think all of us on this call and all of us working with children and families working on social determinants of health have a dream that we want to create a future that really benefits everybody equally. And but a lot of times we get kind of stuck in what we're doing and wondering, are we really making a contribution? And he said also, Victor Hugo said, many great actions are committed in small struggles. So a lot of the work that you're doing, as small as it may seem, it really is part of what we really need to do to collectively create the conditions in which people can be healthy. And certainly here I am in Minnesota, the land of Lake Wobegon. We're one of the healthiest states in the nation. I got the #1 healthcare system in the nation according to the Commonwealth Fund. We've got low infant mortality rate overall. We've got longevity that's really quite good. So taking clues from Garrison Keillor, Minnesota, where the women are strong, the men are good looking, and all of our health statistics are above average. However, unless you're a person of color or an American Indian. And I've been in Minnesota for many years. I moved here in 1980 and working in the maternal and child health program for the city of Minneapolis. And it struck me that the disparities, the top line here is the African American infant mortality rate, and the red line is the white infant mortality rate in Minnesota. and it struck me that there was a large disparity, and was really worked on that for many years when I was in the maternal and child health world. But then coming in as health commissioner in 2011, I recognized the fact that the U.S.-born mothers, black mothers, had an infant mortality rate of 10.2, which was still higher than the white infant mortality rate in 1980. So in from 2011, from 1980 to 2011, the African American infant mortality rate still did not match the white infant mortality rate in 1980, and that's an unacceptable kind of factor, and really highlights the fact that yes, we're making progress, things are going somewhat in the right direction, but they're not going there fast enough, and a lot of people are really disadvantaged. And to think that it's just Minnesota, this is national data on infant mortality rate, and the same thing is reflected, that the black infant mortality rate today still doesn't match the white infant mortality rate in 1980, which really says that we have to do things differently. And this is in a society where we have probably the best medical care in the world, recognizing that we have to deal with other issues other than just medical care. And we also recognize, certainly as health commissioner, that the disparities in birth outcomes are really just the tip of the iceberg. All of the other factors that we work on a regular basis, all of the medical conditions, all the social conditions, all of the bad outcomes, we have huge disparities that are there, and they really reflect a lot of our social and economic conditions and social conditions within our society. So this is where I, as health commissioner, feel that this is one of our central challenges. If we're going to be a healthy state, healthy community, we're going to have to deal with the disparities. We have to push health equity, and it made health equity the centerpiece of what we're doing with the Minnesota Department of Health. And one of the first things that we have done here in Minnesota is really listen to the community, highlight what their needs are, what their concerns are, and we put together a report called Advancing Health Equity in Minnesota, where it became very clear in our report that the opportunity to be healthy is not equally available everywhere for everyone in the state. And when I look at equity, I really look at opportunities. Is everybody having the same opportunity to be healthy, regardless of your skin color, your language, your geographic location, your gender, your sexual preference? And it's obvious that in Minnesota, that opportunity to be healthy is not equally available everywhere for everyone. And it's particularly striking to me in a state where we have great health statistics and we have great health care, that those disparities are not just because of a lack of access to good health care or to poor individual choices, which is the common narrative that we have. Marilyn talked a lot about, or somewhat about, narrative. That's the common narrative that, you know, if we just had good medical care and people made right choices, we would all be healthy and happy. Well, our data here, and I think which is reflected throughout the country, that the disparities are really mostly the result of policy decisions that systematically disadvantage some populations over others. And that's particularly evident among populations of color and American Indians, the GLBT population. And we labeled it here in Minnesota as structural racism when it was dealing with people of color and American Indians. Even in our own agency, looking at the policies that were in place that structurally disadvantaged some populations over others. As Marilyn mentioned, education funding that structurally disadvantages low-income populations and populations of color. So that's forming the basis of what we're doing here, that focus on the structural racism, calling out race as one of the issues that we have to deal with if we're going to eliminate health disparities. And so for our work, to advance health equity, which is to create the opportunity for everybody to be healthy, we're taking three basic approaches. One, expand the understanding about what creates health, strengthening community capacity for them, the communities to create their own healthy futures, and then promoting a health in all policies approach with health equity as the goal. Health in all policies by itself will certainly give us, take us in a good direction, but you have to link it with health equity because just by dealing with health in all policies without having that equity focus will not get you to where you want to go. And I'll go through each of these points during the next couple of minutes. So expanding the understanding of what creates health. As Marilyn said, we need to organize the narrative. We need to, the narrative is not about, should not be about medical care and individual choices. It's really about a lot of other things, particularly the social policies, the educational policies, the economic policies, and then to expand that narrative and align the narrative and the people and the resources to create the opportunities to be healthy. I'll talk just a little bit about our work in narrative. So we have a group here in Minnesota that really is working on changing the narrative, because that narrative really shapes and frames all of the messages that come forward. And it all evolves from the worldview that then develops that common public narrative that leads to the frames and the messages that are come forward. And I stole this from Marilyn. She was talking about dominant worldview narratives, and that narrative right now is bootstrap individualism. People should do it on their own. They can pull themselves up and make things work if they just work hard enough. In that narrative, it's all about free market solutions. Competition is really good. Let the market take us where we need to go. The government gets in the way. That small government, the smaller the government, the better it is. And that structural discrimination is really a thing of the past. It's really all about individual responsibilities. And that's the common narrative. And I think that's one that we know working in public health is far from the truth. And also I added a couple of things in here, Marilyn, just as I talk about narrative and start to reflect what's going on in some states where education is changing, that science really is suspect, dealing with the vaccine controversies right now and immunizations. And education is for job training. Those are part of the common narrative, so that we know that science is really what we need in many, many ways to advance our understanding of what works and what doesn't. And education is much more than just job training. But that's the common narrative. So when we start to deal with narrative, we really have to start out first about defining what we mean by health. And so we're using the World Health Organization definition that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And also that it is not an end in itself, it's actually a resource for everyday life. That how you can use the gifts that you've been given, the talents you've been given, the energy that you've been given to actually make a contribution. So as you start talking and changing the narrative, you have to talk about what is our end goal. It's really health, very broadly defined. And then we look at what are the determinants of health, and I'm sure most of you have seen this slide before or something similar to that clinical care really is only 10 to 20%, depending on the data that you're using, a determinant of health. And yet we spend most of our resources on that 10%. The major factor is socioeconomic conditions, 40%, and then behaviors are also about 30%, but behaviors are oftentimes dictated by the circumstances in which people live, the context of their day-to-day existence. So if you live in a food desert, if you live in an unsafe neighborhood, if you live in a community with poor schools, if you don't have adequate income, it is really difficult to make good choices about physical activity and nutrition and education. So that I believe that the socioeconomic factors that influence health are much broader than 40%. And that goes along with what the World Health Organization really identified as those conditions necessary for health: peace, shelter, education, food, income, stable ecosystems, healthcare, transportation, and social justice. And certainly individuals live within communities, so that individual, what are the individual determinants? But as we ask people what they really think of as a healthy community, what they think a healthy existence is all about, they talk a little bit about medical care and having access to care, but mostly they say, I want to live in a safe neighborhood, I want to live in a place that has good recreation, I got access to food, I can get to where I need to go easily and safely, I have a roof over my head and stable, secure housing, I need to have a job, I feel safe, and I have neighbors that I can interact with in a clean environment. That's the context that people live in, and that's how they define health. So that's where we have to look at individual factors, but also community factors. And this is where I think the framework that Marilyn outlined, that framework to address social determinants of health, is that the World Health Organization put together, and Marilyn and her team have advanced in a very elegant way, help change that narrative by pointing out that really it's the structural determinants, the social determinants of health that have the biggest impact on our health, not the healthcare system. As important as it is, that is not the major factor in determining health. And despite, and then putting this slide together, which was that pie chart that I showed earlier about the determinants of health on the top, but where we actually spend our money, 95% of it goes into the clinical area for medical care. When people see this, they start to recognize that, we have to think more broadly about health, what is health, what determines health, and then we have to think about how are we going to reinvest the dollars that we have. How can we invest them in a more appropriate way, in a more balanced way that creates health? And that's where the framework that Marilyn identified we're using in a variety of ways. I think this is one that all of you should really be paying close attention to and use to your utmost, because it really gives you a way of looking at all of the determinants of health, both the intermediate and the structural determinants, and looking at some of the policies and the systems and environmental changes that are necessary to move forward on all kinds of things. And certainly, as we're talking about narrative, we now know that health is impacted by living conditions, but just knowing that it's not just medical care and personal choices, but it's actually living conditions that impact health. But what we haven't really thought about in the past is how do we change that? How do we act on those living conditions to create health? And that's where the narrative comes in to help us create our capacity to act, where we get the power to actually make some changes in our living conditions that impact health. And that's why we're really working on a way to align that narrative to build the public will, how we align the narrative and the people who can actually impact the decision makers, and align the resources and the infrastructure so that we can collectively change the living conditions through policy, system, and environmental change to create health in our communities. So that was the work on changing the narrative, changing our understanding about what creates health. Secondly, we also work on strengthening community capacity to create their own future, where we do a lot of community engagement, and these are just some examples of the things that we're doing with our Healthy Minnesota Partnership and our Strengthening State and Local Public Health Partnership as a way of really engaging communities. And I'm seeing community organizing as probably one of the most powerful public health tools that we certainly see here in Minnesota. And from our Healthy Minnesota Partnership, where we brought people in from around the state, from all disciplines, all sectors, to really talk about what creates health in our communities. And these were the vision. This was the areas that they really wanted to focus on. They wanted to capitalize, for our state to be healthy, they really wanted to capitalize on the opportunity to influence health in early childhood. Recognizing that our children are really the most important thing that we can really focus on to have the biggest investment in our population. So that was one of the themes that they had. On the other side, on the far right, assure that the opportunity to be healthy is available everywhere and for everyone, really focusing on the equity issues. And in the middle of what they talked about was strengthening communities to create their own healthy futures, recognizing that we really needed healthy communities, empowered communities, activated communities, engaged in all of addressing the social conditions in which people can live. That has been a very powerful tool. Similarly, we have a very strong local public health system, and one of the priorities that I have two priorities. One is advancing health equity. The other is strengthening the state and local partnership for public health. And so our connection with local public health in this work on creating health equity has been a very powerful form and a very powerful force in making that happen. And then lastly, the third area is really promote a health in all policies approach with health equity as the goal. And so we use many tools to do that. We certainly use data, the race, ethnicity, language, and disability data that we're trying to collect in all of the public data sources so that we can really analyze things from the race, ethnicity, language, and disability perspective. Learning how to do health impact assessments, not us doing health impact assessments, but having the community empowered to do the health impact assessments with us as a state health agency or local public health agency as a resource to the community for doing those health impact assessments, because we have seen that when the community does the health impact assessment, they can have a huge impact on public policy that affects housing, that affects zoning, that affects transportation, that affects education. Certainly we're doing some white papers on a variety of issues, but writing commentaries. I did a commentary on the health benefits of marriage when we were having a constitutional amendment about banning same-sex marriages. People did not recognize that marriage is a health issue. It's not just a social issue, it's a health issue. Also been working with cabinet members, organizing all of the cabinet within the Dayton administration, and then setting up a series of questions that people should ask as they're moving forward on advancing health equity, and I'll get to those in a second. So just for an example, I was talking about those themes that we had about capitalizing on the opportunity to influence health in early childhood, empowering communities, and working on health equity. With the community as a whole, recognizing that to get at all of those things with our Healthy Minnesota Partnership, that the indicators had to be quite broad. So as you can see on this slide, that the indicators that we used to hold the health department accountable for what we're doing to improve health was certainly something that would be recognizable to you: prenatal care, breastfeeding, food security. But we also added on-time high school completion, per capita income, sense of safety, small business development, home ownership, and incarceration justice as indicators that we as a health department feel that we have some obligation to work on. These are things that have traditionally been outside of the swim lanes of health departments, but we need to work on home ownership. We need, because I feel stable housing for children is probably the best thing we can do for third grade reading. Incarceration justice, small business development are huge public health issues that the public health community has to weigh in on, focusing on those three themes, early childhood, empowering communities, and equity. And just related to that incarceration justice, I thought it was interesting that Victor Hugo made this statement: he who opens the school door closes the prison. This is all connected. These things do not function independently, and that's why we have to take that the health and all policies approach. And one of the ways that we've been doing that as a health department is doing the data analysis. So when we were discussing minimum wage increase in Minnesota, we wrote a white paper on the impact of income on health. And you can see in this slide that on the left, if you go from low income to higher income in certain quintiles, you have an increasing life expectancy. And on the right-hand side, your disability days decrease as your income goes up. And what's striking to me is that the biggest impact that you can have is at the lower socioeconomic end. That if you can increase the minimum wage and move somebody from the lowest quintile of income to the second lowest quintile of income, you have the biggest impact for any kind of an investment. You can increase life expectancy by about 3.5 years by moving somebody from the lowest quintile to the second lowest quintile of income. That proves that income, that minimum wage, is a public health issue that health departments really need to work on. Right now, in about 2 weeks, we're going to be putting out a white paper on paid parental leave and paid sick leave. And just to give you a heads up on it, our paid parental leave paper will show that paid parental leave is linked to lower infant mortality rates and better health for both infants and mothers. Increase in paid parental leave improves the duration of breastfeeding, higher levels of vaccination, decreasing symptoms of maternal depression, really huge public health impacts. Paid sick leave has fewer occupational injuries, lower post-neonatal mortality rates, more likely people to have cancer screenings, less emergency room. I think it's really interesting that if you have paid sick leave, actually people have fewer days lost due to illness. And then there are huge economic benefits to employers of paid sick leave. So this, in our state, paid sick leave and paid parental leave are public health issues upon which we have to really dictate or provide some data and some information. It brings more people to the table to talk about those issues than just the people in the economic world. It brings the health folks to the conversation table. And certainly our data points out what we all know, that the disparities in access to paid sick leave are really factored in. They're not equally distributed, that your access to paid sick leave is decreased if you're lower income. It's decreased if you're a person of color, an American Indian, or if you have a lower level of education. So that these are structural barriers, these are structural determinants, these are structural inequities that are built into our system that disadvantage the health of people of color, low-income populations, and the lower educated individuals. So that's why we're working, that's why we think our job as a health department is to really provide some information on those social economic issues. As I mentioned, we're working with the cabinet members. I've met with all of the cabinet members and really talked to them about their role in creating health. And this is just an example of the mission statements that have evolved from that with the Pollution Control Agency, working to protect and improve our environment and enhance human health. The Department of Transportation, Minnesota's multimodal transportation system maximizes the health of people, the environment, and our economy. The Housing Finance Group has made their mission statement, fostering strong and healthy communities. They're recognizing that they have a huge role to play in health, and so that they're partners with us in creating a healthy future in Minnesota. And finally, we have put together a series of questions that we're asking to move this forward, this health in all policies and this equity issue, by asking certain questions on the path for change. And I think you can use some of these questions. When you're looking at policies, what are we really trying to get at? Who's benefiting? Who's left out? What should be targeted? In the process of getting there, who's at the decision-making table? Who has the power at the table? Who should set the decision-making table? And who's being held accountable for what's happening on that? And then certainly we have to think about the assumptions that we make, the narrative that we bring to the table, the values that we bring to the table. And we keep asking, what would it look like if equity was the starting point for every decision-making? So when you talk to hospital boards, if you talk to county boards, if you talk to school boards, if you talk to business boards, ask the question, what would it look like if equity was the starting point for your decision-making? So that's where we're going. As Victor Hugo said, there is one thing stronger than all the armies in the world, and that is an idea whose time has come. I think the time has come for us to really work on health equity, because I think it is the central challenge, not just in Minnesota, but it's certainly the central challenge in our country, and we need to work on it together, and I think we're making some progress in that, and I hope you're going to be partnering with us. So with that, thank you very much.
Wonderful. Thank you, Dr. Ellinger, for sharing with us what I'm sure is just a glimpse into all of the work that you're involved in around changing the narrative and in working with partners and different systems across the great state of Minnesota. We're doing pretty good on time, so I'd like to invite you, Dr. Ellinger, to share your thoughts on this next question, and I'd really like to return to it at the end during our designated Q&A session. But can you tell us about the strategies that you've found to be effective for community engagement?
The approach that we've taken is to, particularly with the health equity, I'll use this as an example, our Advancing Health Equity Report. We first, before we wrote our report, we actually went out into the community and asked questions about what's creating health in your community. And from that input we got from over 1,000 conversations throughout the state and all of the website input that we have, opening it up as broadly as possible, we then wrote the report and asked the community if they heard their voice in that report. If they didn't hear their voice in that report, we rewrote that part of the report until the people who provided the information for that actually heard their voice in the report. That has been the most powerful community engagement strategy that we have had so far, because it became the community's report, not the health department's report. It also allowed them, it gave them voice to challenge us when we were saying things that didn't make any sense, and challenge us in a way that was very appropriate to help us get better, and it really created a partnership between us and the community. So really asking for input early on, making sure that you always ask the question, who's at the table in the decision making, who has the power at the table, and is health equity the centerpiece of that conversation. We're starting to find the best way to get communities engaged is get people from the community at the decision-making table. So we're always asking that question, and we're finding that to be really, really powerful.
Terrific, thank you, and very important to bear in mind. So moving along, our third speaker is Dr. Steve Wirtz, who's been with the Safe and Active Communities branch within the California Department of Health since 1998. He's a California native and received both his undergraduate and graduate degrees from California State University in Sacramento. He earned his doctoral degree in psychology from Boston University and gained research and epidemiology experience working at the Boston University School of Public Health. He's a licensed psychologist with expertise in developmental psychopathology and community psychology. Dr. Wirtz manages the Injury Surveillance and Epidemiology section and works on a wide range of projects, including the department's 5-year CDC Essentials for Childhood initiative, as well as other training and technical assistance projects in the areas of child maltreatment, substance abuse, and prevention and evaluation planning. Now with our final presentation for the day, I will hand things over to you, Dr. Wirtz.
Thank you very much. I am very pleased to have this opportunity to showcase some of the important work we're doing in California. It has been impressive to hear already what's been presented. So there are so many individuals and organizations working in California to promote child well-being and equity. I can't begin to acknowledge all of them here, but suffice it to say that the small part I'm going to briefly review with you today is only the tip of the iceberg in these broader statewide efforts. Through the Essentials initiative, we simply hope to be able to contribute to this ongoing effort. In other words, we are standing on the shoulders of many others in California. And so I'm going to set the context a little bit by just looking at California's diversity and some of our major policy context. Mention, of course, again, our social determinants of health and health equity frameworks, and then say a little bit about the status of children in California. And adding one thing I think was mentioned but hasn't been highlighted, and that's sort of the life course view of things. And then talk a little bit about our Essentials initiative and how it fits into these broader contexts, and finally give some examples of some of our very early on successes as a collaborative. So the first thing to sort of recognize about California is really how large of a state we are. Approximately 38.8 million people. We're the 7th largest economy in the world, and we even have a balanced budget. But of course, it is at a high price for our population. California's population is larger than a total of 22 other states. LA County itself is larger than 11 states. So obviously, I am not speaking on behalf of the state of California by any means. It's also a very diverse racially and ethnically, and that's what I wanted to highlight with this slide. The most important point for our child equity focus is the fact that 73% of California youth under 18 are identified as people of color, with white youth making up only 27%. And as you can see on the right side of this, Latinos represent the majority of youth in California. So I'm going to then just sort of set the stage. Obviously, we've talked a little bit about the federal context already, and I'm going to just note here that the National Prevention Strategy does focus on health disparities. But I want to talk a little bit about California's policy initiatives that really sort of positioned us before we took on the Essentials project. The legislature in California and the governor signed legislation back in 2008 creating a strategic growth council that had the heads of all the primary agencies in the state to plan for the future. And part of their mission was to achieve sustainable communities that promote equity, strengthen the economy, and protect the environment. So we've had this framework that acknowledges equity for a good while here in California. We also then created in 2010 a Health and All Policies Task Force that has been functioning for a good while to advance these goals, and that is placed in our Department of Public Health here. The biggest framework we have driving our work in the Health and Human Services Agency, which our Department of Public Health sits in, is really this Let's Get Healthy California Task Force. Again, another governor executive order formed in 2012, and they have produced a report that sort of sets the frame for our discussions in California for policy and equity. And finally, more recently in 2012, we've created an Office of Health Equity. So both, and Health and All Policies has been integrated into the Office of Health Equity. So we clearly see that Health and All Policies needs to have an equity lens as well. So just to look at our Let's Get Healthy California framework, you can see that one may have taken a lifespan kind of focus. And of course, Essentials fits over on the left side of this chart with the Healthy Beginnings, in part, obviously, but that's where it just sort of fits in terms of Essentials for childhood. But you notice also that health equity should be fully integrated across this entire effort. So again, I'm going to just say that we've all seen this slide, and we're very familiar with this in California, and so is everyone else, I think, in public health, or most of you in public health. In fact, I wanted to just sort of highlight that in California, we've had a very good start with the social determinants of health model for quite a long time with the Bay Area Regional Health Inequities Initiative, BARHI. And this is another view of this recognition that structural determinants of social status set the broad structural approach that we have around changing social norms, policies, and systems change. It's obviously not enough to focus only on the social services expansion and program improvement. And I want to just show this. This is from Paula Braveman, and I just think that it's a nice way to look at how that model plays out again. That, as we've learned, Marilyn did quite a good job of this, but I want to just highlight the reality that social stratification obviously leads to differential exposure, differential vulnerability, and differential consequences, which then further feed back into a generational continuation that continues to reinforce differential education, occupation, and income, differential risk and protective factors. And this helps explain one thing. I think it's really critical that Marilyn's definition of health equity included, and that is sometimes universal interventions and innovations can in fact lead to worsening of disparities. Take the internet technology divide, for example, because those with resources can better take advantage of the opportunities that they're given, and those with social capital get more, and those without don't get more. So it's just important to sort of recognize universal interventions without an equity lens may not even address the health inequalities that we are trying to focus on. This diagram just gives you a flavor for the lifespan kind of notion. A child born into poverty is exposed to environmental inequalities, family stresses and dysfunctions, risky behaviors, child welfare involvement, social exclusion and isolation, and these cumulatively add up over the lifetime, and we often end up with what we have in certainly in areas of California and around the nation, which is communities with highly concentrated poverty that is generational and has fewer opportunities and resources for healthy behaviors, and in fact reduce and limit the income opportunities, which can then in fact lead to illegal activities or underground markets and so on. You can see this in many ways. This is just this notion of the cascade of risk that accumulate across the lifespan that continues to produce these differential outcomes. So I just want to then switch with this framework, just briefly highlight some of the information about the status of children as it plays out across the lifespan. And here, these numbers come from California has a very excellent data system for the child welfare system at the partnership with the Department of Social Services and the University of California at Berkeley. And these data often are available, very close in real time compared to most data systems. And as you notice, I put up both child reports and substantiations, and one of the things that's tended to happen over time is reports have either remained the same or increased while substantiations have tended to go down. And it's important, I saw some of the notes, that obviously Black and Native Americans have in California potentially around 3 times higher rates of substantiated cases. But when you actually put socioeconomic status together with race, as Emily Putnam-Hornstein has done in multiple of her articles and her team, you don't get those same differentials when you control for poverty, although death data is different in that regard. Also, the economic cost has been estimated in California at $15 billion for the child maltreatment cost, so we try to at least keep aware of what might be return on investment issues. So now just briefly, going across time frame that we looked at it at that flow from poverty from birth to bad outcomes, California has the highest child poverty rate in the nation at 23+%. However, if you look at this chart and you look at the black infants under 6, 38% of black infants are in poverty, and for Hispanics under 6, it's 31%. California's children are more than twice as likely to be poor than our seniors. That's where they start. Oh, excuse me. That carries out, as we've seen before, to poorer status in high school graduation, and that translates into occupation and income, as we've seen in a dose-response kind of way. And here is California data around life expectancy, where an Asian American baby born today in California can expected to outlive an African American baby born the same day by more than 11 years. We've also looked at this geographically. There's a 15-year gap separating areas in California with the longest life expectancy from the shortest, as you can see, from Newport Beach to Watts. And even within a metro area like San Francisco, we've got an 11-year gap between parts of Oakland and parts of San Mateo. So that's the background. This slide is just sort of to help you change gears into solutions, we hope. And so the Essentials project for California here for safe, stable, nurturing relationships and environments, you've all seen CDC's 4 goals, and I think the main thing to point there is that those are not only data-driven activities, but also social norms changes, systems changes, and policy changes. And for California, we have chose to set up our backbone organization. I'll talk just briefly about the collective impact approach, but our backbone organizations are a partnership between our Department of Public Health and our Departments of Social Services, the Office of Child Abuse Prevention, which we felt was really an ideal situation to bring both the child welfare system and our public health system together. And we're finding that the main thing we're finding, and we knew from the beginning, is that California is very rich in partners and efforts underway, and I'll talk about that a little bit before as we go along. Of course, our vision is very simple about all children and youth and their families thriving in safe, stable, nurturing relationships and environments. And our goal is to create a common agenda across multiple agencies and stakeholders. And I'm going to highlight this to align and enhance activities so that all children thrive, in essence, and I'll come back to this enhance. This is just some of the partners we have on our efforts so far, and every day we're finding more groups and partners to join with, and I think one of the big tasks that we all may have is how to make that work well together, and that's where we are stressing this aligning and enhancing efforts to create systems and program improvements, social norm change, policy change, and we think that adding the public health perspective drives us to address the upstream structural determinants as well. Don't want you to be able to read this per se, but I just want to tell you that we have set up a common agenda. We have 10 goals. One of those is an equity goal, and we have 4 work groups. One is around program and systems integration across sectors, And the next one is the community engagement and public awareness piece. I think we've heard some really great discussion about framing around that in the child maltreatment area. We know that Prevent Child Abuse America with Doris Duke Foundation had done so much great work with frameworks to understand some of these, the narratives that we just heard about, the individualism, the family bubble, and others. Our third work group is around public and private sector policies, and I think it's important to recognize that not all policies are going to be at the public level. We're looking at business practices, policies, and procedures, certainly around paid leave and sick leave and so on. And finally, the shared data and outcomes piece, and I'll perhaps get a chance to say something about that as well. But I do want to just take a minute to say that we did buy into the collective impact approach, and of course most of you have heard the concept and it's starting to become jargon in some way. But for me, it has actually been an important organizing tool, and what I say, I reduce it down to saying it is just collaboration, like we've been doing forever, but just done very, very well. And to do it very well means to truly take these words to full impact. It's a commitment of a group to focus from different sectors on a common agenda on specific problems. Large-scale social change requires broad, cross-sectional coordination. It's not enough to have isolated interventions and individual organizations, as we all well know. Just to mention, these are 5 of the characteristics that FSG and others have documented as being what has to work really, really well to make joint efforts be successful. The common agenda, shared measurement, and I'm going to stress this, mutually reinforcing activities, because in California we're so large, there's so many aspects, we're a decentralized government structure for the health departments and for many other things. And so there's no way that any single structure could do this. We're trying to figure out how to develop networks of well-functioning, essentially collective impact groups that can then align and enhance each other's work and mutually reinforce their activities by divvying up different tasks or sharing them as need be. So communication becomes critical, and obviously the backbone as well. And this is just a very simple picture of this, that if we have 10 wonderful coalitions working on great things, they all may be doing their piece, but at times their impact becomes isolated, and if we can align those better and enhance each other's efforts, we can be more likely to have that focused effort in one direction to make progress. That's really helped both in terms of communicating with our teams and trying to integrate with other existing groups and collaborations and systems and initiatives. So I'm going to just briefly go through 3 examples of, we're very early on in our actual planning. Our work groups have met already. We're still working through, I have a meeting this afternoon on sharing across several of our major players and a commitment to shared data and measurement. One of the exciting things that happened in California, First 5 California is a major player in terms of supporting all the layers of work from program activities to policy and communications. And they had their First 5 Summit, and our Health and Human Services Secretary was one of the closing speakers. And the First 5 people, independently of us, through just being part of our collective impact, made contact with her ahead of time and asked if she would make a public commitment to working with First 5 and the Essentials and other departments within her agency on shared measurement. So we were just extremely pleased, and it just demonstrated that when people are doing mutually reinforcing activities, things happen that you don't even know about that are central to your own success. So it was just great to see that. So I'm going to take 3 things that we've actually been involved in already. The first is this passage of AB 420, which put limits on the use of willful defiance suspensions for schools The second was the California Assembly and Senate unanimously approved a concurrent resolution on trauma-informed practice and care to reduce children's exposure to adverse childhood experiences. And our infant safe sleep regulation process within child care settings has moved forward, and the Department of Social Services is now, I don't know if finalizing is the right word, is in the process of the regulatory process to finish new regulations that will put clear guidelines for licensed child care on infant sleep practices. Now, each of these three areas actually address disparities in a pretty direct way. So with the willful defiance, our state superintendent of schools, by the way, was at that same meeting, and he too agreed to the shared measurement piece. But he reported 600,000 suspensions, 43% for willful defiance in California in 2013. And he also pointed out the disparities in suspensions for children of color. And obviously the biggest one here is African American students only make up 6.3% of the total enrollment, but 16.3% of the suspensions. And Hispanics have a slight disparity as well. What we were able to do with regard to that was to come and bring public health data to the discussion. While other partners brought students and model programs and advocates together, we came to testify providing data from our California Behavioral Risk Factor Survey on child trauma and the adverse childhood experiences. We testified at both of these hearings. The first one was connected to Assemblymember Dickinson's willful defiance bill, and the second one was connected to the concurrent resolution. And what we essentially said, I'm not going to go through this much, but we essentially laid out the argument about the science of early childhood development, and we used the ACEs framework to talk about disrupted neurodevelopment and toxic stress. And then we provided some data from the adverse childhood experiences module used on the BRFIS in many states now. With just on this 1 year, the sample size was almost 10,000. And as you noticed, and probably people understand, the 8 or so measures here are all tend to be on the health behavior realm of Maryland's social determinants model. And we know, for example, that there are other tools now that are getting better at measuring the community components. So the National Study on Children's Health has measures on community violence, and even in California, our maternal infant health assessment, MIHA survey, asks pregnant women a series of questions about lack of access to stable housing, food insecurity. So we recognize that trauma comes in many forms and is not just at the health behavior level. But just looking at this data real quick, of course, over 60% of Californian adults report at least one ACE, and some 25% report 4 or more, or excuse me, 23 or more for 25%. So in summary, on the ACEs data, we have tons of data showing that childhood trauma is very common, and they're not just ACEs that cause trauma, but rather social and community conditions. And these extreme traumas tend to cluster together to produce a cumulative impact. Poverty increases the negative impacts of these traumas, and the health impacts are across multiple domains. We've heard this: social economic impairment, unhealthy behaviors, mental health problems, physical health problems, chronic diseases. However, we have learned too from the ACEs work throughout the country, from ACEs Too High and ACEs Connection and all the incredible cities and towns and states that are doing work. Prevention and recovery are possible, but it will take collaborative, multi-sectoral approaches to succeed, like health and all policies. And then just touching on the infant safe sleep piece, there are differential death rates among infants of color from multiple issues, but certainly from sleep-related deaths. Sacramento County shows the death rate twice as high child license care policies and procedures are one of the areas where there's not, the regulations in California at least have not lived up to the new knowledge. The same with hospital policies and practices. And there are a variety of existing efforts. LA has a very strong effort going on. Sacramento County does as well. So with that, I'm going to just leave you with this wonderful picture from our Office of Health Equity with our goal of fostering equity. So thank you very much.
Thank you, Dr. Wirtz, for talking with us about what is such impressive work. And now that we've heard from all of our presenters, I'd like to spend our remaining time addressing just a few of the really many important questions that have been submitted. And those that we don't get to, we're going to collect those and share them with our presenters following the program, and we'll do our best to respond. So clearly 90 minutes is not sufficient to dive into something so complex, but I think this is certainly a start. So I'd like to, again, start us off by posing that first question that came in and direct it to our partners at CDC. So can you clarify for us, how is child maltreatment defined, and what is represented in the data? Are you looking at just substantiated reports? And Dr. Wirtz talked about what the data looks like in California, but I'd like to give you an opportunity to answer Marilyn or colleagues at CDC, because it might be helpful to know if there's a standard definition of child maltreatment.
Hi, everybody. This is Joanne Clevens at the CDC. I am reading from our CDC uniform definitions for surveillance purposes. And what we have defined child maltreatment as is any act or series of acts of commission, that would be abuse, or omission by a parent or other caregiver, omission would be neglect, that results in harm, the potential for harm, or threat of harm to a child. Now, although we have these definitions for everybody, what actually happens in our surveillance system probably is not picking up all the cases of child maltreatment. For evaluating our essentials efforts, we are taking all reports of child maltreatment in each state, not just the substantiated reports, based on what researchers have identified as not really finding very many differences between substantiated and not substantiated in terms of outcomes and risk factors. So we're taking all reports to measure the impact.
Thank you, and thank you for the detailed response. I think it's helpful for our understanding. For our next question, I would like to return to Dr. Ellinger, and I want to ask you a part two of the question that I asked previously. There was a follow-up question that was asked, and it was, in developing the report that you used in your example, who in the community did you ask? And can you expand on that? The heart of the question seems to be, and as stated, did you ask leaders or everyday folks?
We did both. We have lots of constituencies. We have lots of advisory committees. We have lots of partnerships. We certainly made it available, the request out to all of our partners and members of those organizations. And particularly with community organizing groups, we let it be known that we wanted broad input. So we particularly went to community members and asked our local health departments to also do those kinds of connections with groups that we would not have direct access to from the state health department.
Great, thank you. Finally, we have a question. Again, this is directed to Marilyn and our partners at CDC. You mentioned at the end of your presentation, Marilyn, there was new research on exploring policies for reducing child physical abuse and neglect and analyzing environments and conditions. Who is doing that research, and are findings being made available at this point?
So I keep good company, and I'm going to turn to my right again, my colleague Joanne Clevens, who's actually the first author on that policy scan. And I think Ms. Joanne wants to add something.
The policy scan is published in Child Abuse and Neglect, and what we did was we consulted with several experts in different sectors to identify policies with the potential to impact social determinants of child maltreatment. And what we were trying to do was, first of all, identify what kinds of policies we needed to be thinking about, but also trying to identify data sources in order to start evaluating policies. So that report is in Child Abuse and Neglect. I believe it came out in March.
Thank you, Joanne.
Last year, March, so 2014.
Great, thank you. And again, we have just 1 minute left in our program today, and we have many additional questions that were submitted, and I wish we could get to them. But what we're going to do is close the loop with our fantastic presenters today and get you some satisfactory responses. So again, I'd like to take this opportunity just to thank everyone for attending today. I hope you found that this conversation has been valuable and that it sparked some questions for you and serve to help you think about the ways in which you could work with various partner groups as well as other entities across the state and in your communities to consider health and health equity in all of your decision making. So before we close, I'll extend another sincere thank you to our presenters for their commitment to these issues and for their insightful remarks throughout the program today. We appreciate the CDC's National Center for Injury Prevention and Control for sponsoring today's webinar, and we've enjoyed hosting you this afternoon. So please remember to share your thoughts with us through the online evaluation form. And with that, we'll conclude, and I'll wish you a very happy rest of your day. Thank you, and you may now disconnect.